Three numbers that tell the whole story. Nurses spend 53% of their shift on administrative tasks, not patient care. Hospitals lose $4.75 million per year per facility to nurse turnover. And 30% of critical patient information gets lost during shift handovers. That is not a staffing crisis. That is a data fragmentation crisis. And it is the most expensive problem in healthcare that nobody talks about. I'm Chris, 20 years in healthcare, the last decade in cloud and AI. I'm the healthcare architect. In this video, I am going to show you why nurses are drowning in disconnected systems, what that fragmentation costs, and the architectural fix that changes the equation. Not another app. A unified data layer built around how nurses actually work. Imagine standing in a nurse's shoes for 30 seconds. A patient is waiting. Medications due, that lives in the EHR. Supply inventory, that lives in a supply chain system. Who is coming on the next shift, that lives in a scheduling module. Which patient is most critical right now? That does not live anywhere. She builds that picture in her head from scratch every 10 minutes on a 12-hour shift. Nurses are the integration layer of the hospital, the human API connecting patient needs to institutional resources. Hospitals have given them a time clock app and a prayer. The wasted time adds up fast. A study found nurses spend only 21% of their time on direct patient care. European data shows 23% of a 12-hour shift goes to EHR interaction alone, chasing information across 5 systems, re-entering the same data into multiple platforms. The EHR was designed for billing, the scheduling system for payroll, none of it for the nurse at the bedside at 3 a.m. The financial bleed matches the operational. The NSI National Healthcare Retention Report shows hospitals lose $3.9 million to $5.7 million annually to nurse turnover. Replacing one experienced nurse costs $40,000 to $88,000 when you factor in recruitment, onboarding, and temporary staffing. The nurses who leave are not the new graduates. They are the experienced hands whose institutional knowledge walks out the door and does not come back. The root cause is simple. Nurse-relevant data lives in at least 4 systems. The EHR, the HCM platform, the supply chain manager, the patient satisfaction system. None talk to each other. None were built for the nurse's workflow. The result is a context-switching tax that burns people out and puts patients at risk. When a nurse cannot see the full picture in one place, prioritization suffers. When handovers rely on verbal summaries, critical information gets lost. The Joint Commission reports communication failures factor into 30% of all malpractice claims. A falling sodium level, a family concern from 6 p.m., a medication held pending a consult. None of that travels unless someone writes it down and remembers to say it. This is the invisible failure mode of hospital data architecture. It does not make headlines. It just quietly burns out your best nurses, raises your adverse event risk, and costs you millions. The fix is not a new app. A coherent data architecture that treats nurses as the operational core of the hospital. The principle is simple. Unify the data layer. Surface it in context. Let AI handle the coordination so nurses can handle the care. This governance gap is not unique to healthcare. Banking has 15 years of model risk infrastructure built around Federal Reserve Guidance SR 11.7, yet even that mature framework struggles with autonomous AI agents. Healthcare has no equivalent scaffold. Only 18% of hospitals report mature AI governance, with a median 2026 budget share of just 4.2%. The lesson from finance is clear. Build governance before deployment outpaces accountability. 4 use cases drive the highest return. Admission and intake. What if an ambient AI could listen to the patient conversation, pre-fill intake forms, and flag that room 412 needs attention before room 418? Not a diagnosis. A priority signal from data already in your systems. The nurse reviews. The documentation writes itself. Task prioritization. A patient whose antibiotics are due in 20 minutes and whose oxygen is dropping needs to jump the queue. What if an AI agent ranked the task list by acuity, medication windows, and workflow dependencies in real time? The nurse still decides. The machine stops the list from lying about what matters most. Shift handover. This is where information loss happens. An AI agent could synthesize 12 hours of data into a structured SBR brief and push it to the incoming nurse's phone before she sets foot in the unit. The handoff becomes a confirmation, not a reconstruction. Supply replenishment. What if an AI agent auto-triggered restock orders the moment inventory crosses a threshold, routed it through approval, and surfaced a confirmation in the nurse's workflow? The supply chain becomes invisible infrastructure. Each of these connects to a real cost line. Better handovers mean fewer adverse events, and fewer adverse events mean fewer malpractice claims. The Joint Commission puts that number at $1.7 billion across the industry. Smarter task prioritization means less overtime and fewer agency nurses, at up to $88,000 per replacement. Auto-replenishment means nurses stop playing inventory clerk. The architecture pays for itself in reduced HR spend. Recruitment, hiring, onboarding, contract labor, and your nurses want to stay. What this looks like on the floor. A single mobile screen pulling patient information, tasks, supply status and schedules into one view. Dark mode, designed for the night shift. The nurse opens it and knows who needs attention first, which medication windows are closing, and whether the supply room is about to run dry. Built on a unified data layer. The agentic layer makes this different from every app that has failed nurses before. Not a chatbot waiting for a prompt. An AI agent watching live data, acting before the nurse notices the problem. Vitals cross a threshold, the task list reprioritizes, the supply order triggers, the handoff brief generates. The nurse decides at every node. The agent drafts, the human approves. Always. Your EHR, your HCM, your supply chain manager, your scheduling platform, they all have the data your nurses need. They were never connected for the nurse's workflow. Unifying that data layer is the work. The mobile experience is the surface. A coherent data architecture is the foundation. So what do you do with this? Start with handover. Clearest ROI, most contained scope. Communication failures during transitions contribute directly to adverse events. An AI-generated SBR brief pushed to the incoming nurse's phone is a high-impact starting point. The data already exists in your EHR. You are surfacing what you already have. Expand to task prioritization. Overlay acuity scoring on the existing task list. Let the nurse see who needs attention first, ranked by clinical indicators. Layer in supply replenishment. Connect inventory thresholds to your supply chain manager. Auto-trigger restock orders before the nurse notices the shortage. Finally, the intake scribe. Ambient AI listening to the admission conversation, pre-filling forms, generating a risk flag, not replacing judgment, giving the nurse a head start. The nurses who leave are not leaving because they do not love the work. They are leaving because the work is designed to make them fail. Fragmented data, disconnected systems, information everywhere except where the nurse needs it. That is what burns people out. That is what a connected solution fixes. Implement the architecture. Deploy the AI agents. Cut your recruiting costs. Slash your agency nurse spend. Reduce your liability exposure. And keep the nurses you already have. Build the foundation, the rest follows. I am the healthcare architect. See you in the next one.